Thank you very much, Ulrich. I continue to learn a great deal from you. Next, we have Hannu Paajanen, who is well known to most of us, and he really is a person who I think has extended and broadened the horizon with respect to hernia repairs, and I think he probably goes beyond that as well, but he's really been has devoted a tremendous amount of his life to the development of his techniques with respect to fixing these things. Hannu?
Thank you. Thank you, Ulrika, for a very nice presentation. This mesh complication is not seen by me. Hope. So, okay. So my task is now to give a little bit overview of the laparoscopic techniques of chronic inguinal groin pain. So that's very difficult thing because now it's because we don't really have a good evidence of this surgical treatment of chronic inguinal groin pain. It's really eminence-based rather than evidence-based, and there's very few well-done studies. What is evidence-based medicine surgical treatment? I have found only 2 randomized studies of this field, and we really need more comparative studies of different techniques because very many surgeons are operating with many different techniques, as Dr. Mushavec told us. So almost everybody says my technique is best, and I call this eminence-based surgical view. It means that this number 6, 7, and 8 are holds true in many surgical departments, and clearly this is the way I do it, and it is the best way. So this is the evidence-based level in surgical treatment, and it's shame to be a surgeon and present like this data. Chronic inguinal injuries in sport. Of course, very, very important topic is this posterior wall weakness we just heard, but I think there's a lot of more diagnoses, and the surgical treatment of those are not simple to suture the posterior wall, as we heard. In my practice, very many soccer players, they do have adductor-related pain, and of course this posterior wall pain, but rectus abdominis and pubic-related pain as well, and we must tailor our surgical treatment for very specifically there where the pain is coming. It's not always the posterior wall. There's very many diagnoses, and that's why we are here now to discuss all these talks about this. I think that this chronic inguinal pain is a dynamic process. It very often it begins from the adductor, but it can in a way climb up to the posterior weakness and also go to bone marrow. So it's a pain circulation, it's a pain triangle, and how to treat this triangle in a surgical knife, it's a really task for us. At present, this is my personal view, don't be angry of this, but at present I think we don't know much about real exact pathophysiology of and correlation to pain in chronic inguinal sport-related pain, and we don't have a real good imaging correlation to pain. So we don't have a good, reliable operational findings correlated to pain. Although we saw this genitofemoral nerve, it might be so, but there are other reasons as well, and we need a bunch of more studies to be convinced what is really happening in the painful groin. Of course, there's a nerve problem there because there's pain, and there's many nerves in the inguinal region, and it would be very simple to just say to surgeon, okay, go there and cut the nerves and no pain. But I don't believe this is the the whole answer of this difficult problem. We need more, and we need more studies. Very many surgeons before me have been doing research of this field, and we have a lot of retrospective data, and this open surgery, either using a mesh or not mesh, usually the recovery rate is 70 to 90%. And all these are non-randomized cohort series of 1 or 2 surgeons or 1 or 2 clinics. And of course we have a lot of laparoscopic surgery done, and the recovery rate is about the same. The first, by the way, was the British surgeon in Groin over 10 years ago using a laparoscopic technique. As we heard, this open techniques usually is focusing on the posterior weakness, and we can transect the nerve as well, and it works. I have also done this operation recently, and no problem, it works. But it's very sniper type operation, just focused on the posterior wall, and it fixed the problem if there's a problem in the posterior wall. And if you are using a laparoscopic techniques, you are usually introducing the mesh behind the pubic bone and all this complex musculotendinous system, and it's a more wide operation, more indication, more widely done, and it heals more wide problems or disorders in the groin area, because the mesh covers most of the important tendons and muscles behind the pubic bone. And of course it covers the posterior weakness and heals this, but honest, I don't have noticed these mesh problems we saw just now, but maybe it can happen, I don't know. So most of the treatment, of course, is conservative, and as a surgeon I must say that I only operate about 10% of chronic inguinal pain. Other doctors are sending me, so it's not a first one operation. This 2 months is okay for top level athletes, but I can wait 3 months, 6 months if I have an amateur. No, it's not a rush to operate those patients. Most of those heals without surgical treatment. And this laparoscopic technique is extraperitoneal, we call it TEP, or through the abdominal cavity, which is TAP. And we can combine some nerve release, tenotomies, drilling of the pubic bone. We listen later of this, and never use any symphysis plates. This is old-fashioned, but sometimes you combine something with a laparoscopic technique as well. We heard about this posterior wall. We can use downplication or mesh. I think the collagen is the best friend of the hernia surgeon in sport groin pain as well, and you are producing surgical trauma, hematoma, and collagen synthesis there, and it heals these patients. Nothing about Liechtenstein. This laparoscopic techniques is a minimally invasive techniques as well. If you look at the skin, you just make small holes, but beneath the skin, behind the pubic bone, you are really making a large wound. So it's not a minimally invasive inside, it's minimally invasive on. You must realize this, and nowadays we never use any tackers when we put a mesh in, because it's invasive to use tackers. Then some surgeons in England, they are using this release operation and put a mesh on the tenotomy of the inguinal ligament. I am not doing this, but this is one way to do it. No evidence-based data of this. The first one evidence-based study in surgical trial was coming from Sweden many years ago, and they compared 4 groups, surgery, draining, physio, and controls, and they found that surgery, open surgery, plus sinusoplasty was best. The second one we have done in Finland, and it was referred in the morning. We treated 60 patients with sportsman hernia, or athletic pubalgia is the best term, maybe now, but tomorrow something else. We collected our patients 3 years in the southern part of Finland, And our aim was to compare whether this laparoscopic technique, extraperitoneal, is better than additional physiotherapy. And we image every patient with MRI to really find what exactly is the origin of the pain in these patients. I can tell you that to make any randomized studies in sport groin business is very difficult, because most of the DAPA athletes, they don't want to participate this, and they want laparoscopic surgery or open surgery. They never want to any comparative studies of physio anymore. But we found 60 patients to our randomization, and 30 plus 30, and we have, this is the sport they were doing, most of those soccer players. We tried to make very carefully our study and concert statement and power calculation. Laparoscopic technique heals 90%, conservative 50%, and we need 25 patients in each arm. And our strategy in extraperitoneal mesh placement was that it covers more than posterior wall, more vulnerable areas. And you can see here this patient had a rectus muscle rupture, and there's a needle which I put skin mark and a needle, and I can put the mesh exactly the right place where the pain is originating. So it's easy in laparoscopic technique to do like this, and no fixation of the mesh. And sometimes we make adductor tenotomy because there's a very prominent adductor pain and this sport pain above the inguinal ligament, and 6 patients in this trial was also done tenotomy. And results, we have heard full return to sport in operative group after 1 month, 70%, and complete relief of pain after 1 month, half. After 3 months, 90% versus 7%. So operative technique is good in certain cases when the pain is very, very difficult. And here pain scores in laparoscopic technique, non-operative technique, so it works. This is odd to me, or weird, that sometimes this mesh behind the inflamed symphysis also heals the osteitis pubis type pain, and I can't explain why. Maybe it stabilizes the pubic symphysis somehow. So why to use mesh instead of this minimal repair? I think it's more, the indications are more wide. Mesh stabilize all these tendons and muscles behind the vulnerable area of the inguinal region. Of course, it produces scar tissue and collagen. As I say, collagen is the best friend of the laparoscopic surgeon as well. And it may absorb some muscle fibrosis, I don't know. And of course, some neurolysis is always happening when we are operating. We are cutting at the periost nerves, which are irritated in these patients. So this mesh covers a really wide area of the pubic bone, behind the bone. So, but I'm a Finnish guy, and I'm still on a very thin ice when I'm discussing of this, because we don't have hard data of how laparoscopic or open technique is really doing. Is it surgical trauma? Is it collagen? Is it this bullet technique Dr. Musavek told? I don't know. We need more studies, and we need to compare different surgical techniques. I don't know what is the role of bone marrow edema in this pain, and what is the role of new treatment, Botox or platelet-derived growth factor injection. I don't know. We have to make more studies. And currently we are running this minimal repair technique versus laparoscopic technique in Finland, in Malmö, Sweden, and recently in Manchester, United Kingdom. Dr. Ali Sheen got the permission to participate in this. So we are collecting 60 patients to compare these two techniques and making a good randomized study again. And I think this is the only way how to convince myself and you what is the best surgical technique in this difficult area. So thank you everybody 3 years ago we were in Manchester, surgeons were discussing of this, and I think we are not much more wise after 3 years, so we need more studies. Thank you.